Next, let's look at the details of blood supply to an individual hemisphere. We've already seen that the medial and lateral aspects of the hemisphere have a different blood supply. Now let's look at the origins of the cerebral vasculature. Note that the blood supply to the entire brain comes from two pairs of arteries. It comes from a pair of internal carotid arteries that form by its branches the anterior circulation, and it's formed by the branching pattern of a pair of vertebral arteries whose branches will form the posterior circulation. Note that the anterior and posterior circulations are linked from front to back as well as across the midline and form what is known as the circle of Willis. So let's detail its branches. First off, note that, as we discussed earlier, the posterior circulation's job mainly is to supply the brainstem, the cerebellum, but also the posterior and inferior aspect of each hemisphere by giving rise to a pair of posterior cerebral arteries. So the posterior circulation, vertebrals unite to form a basilar. The basilar at midbrain levels will divide into a pair of posterior cerebral arteries. Those posterior cerebrals are supplying the medial aspect, mainly the occipital lobe, and the inferior aspect of each hemisphere. The two major branches that arise from the anterior circulation are a middle cerebral artery and an anterior cerebral artery. The middle cerebral artery, as you can see, is really an extension of an internal carotid, and it sweeps out to supply most of the lateral aspect of a corresponding hemisphere, whereas the anterior cerebral artery branches acutely from the internal carotid and dives into the inner hemispheric sulcus to provide much of the blood supply to the medial aspect of a corresponding hemisphere. So what links the circle of Willis together are three communicating arteries. There's a very small anterior communicating artery that joins the two anterior cerebrals together by crossing the midline. And there are a pair of posterior communicating arteries that actually link the two circulations together. They provide a link between each internal carotid and each posterior cerebral on a corresponding side, but they're really the weak links in the circulation. Potentially, they provide a collateral blood supply from front to back, but typically in a patient that has had an arteriogram, the arteriogram commonly will only light up either the branches of the anterior circulation or branches of the posterior circulation and not both. The last point we want to make before we look at the details of this is, where are the most common sites where we see the development of berry aneurysms? And the answer is, by a large margin, the most common site of development of such aneurysms is in branches of the anterior circulation, much more than the posterior. The most common site, approximately 25% of the aneurysms that develop, occurs, as we indicate in the box on this figure, right at the branch point between an anterior cerebral and an anterior communicating artery on a corresponding side. Now, let's look at an arteriogram of the carotid circulation. This is an AP view, so this is viewed as if you were looking at the patient. And what we've lit up with a negative contrast and dye injection is the branching pattern of the left internal carotid artery. And as we indicated, we know that the left internal carotid artery is giving rise to a left middle cerebral, whose branches you can see branching extensively on the lateral aspect of the hemisphere, and an anterior cerebral artery that dives, as we said, has a relatively straightforward course supplying the medial aspect of a corresponding hemisphere by going through the inner hemispheric sulcus. So one of the issues that can come up is the exam questions can show you an arteriogram and ask questions such as I've indicated on the slide as to what part of the motor or the sensory homunculus might be supplied by an unlabeled anterior or middle cerebral artery. And as we've already discussed, we know that the middle cerebral artery is going to serve or supply the upper half of the corresponding motor in the sensory homunculus, head, neck, upper limb, and part of the trunk, whereas the anterior cerebral artery will supply the lower half of a corresponding homunculus, including pelvic structures, muscles and skin, and the corresponding lower limb. And then the other point that can be made about this is, remember that we can develop an aneurysm of the internal carotid artery just before it branches into the anterior and the middle cerebral. And as we've alluded to in this anatomy review, obviously the presentation might differ somewhat dramatically if that aneurysm of the internal carotid expands in the medial direction or in the lateral direction. And here's the difference. When I have a medial expanding internal carotid aneurysm, that is likely to compress the temporal optic nerve axons on the outside of an optic nerve on a corresponding side, this being the left side, and this patient would develop a left nasal hemianopsia. But if the internal carotid aneurysm expands laterally, it's likely to involve structures in the cavernous sinus. And the nerve that is traversing just lateral to the internal carotid artery that's likely to be affected initially by the aneurysm will be the abducens nerve. So a patient is likely to develop an internal or a medial strabismus as a result. Next, let's look more specifically at the vascular territories of the anterior, middle, and posterior cerebral arteries. We've already alluded to this, but now we're looking at a couple of views of each hemisphere, particularly laterally, and this serves to illustrate the functional areas served by each of the arteries and their territory. Note that in the unshaded area on the lateral aspect of each hemisphere, that's the vascular territory served by a middle cerebral artery. Obviously, the left one on the left side, the right one on the right side, respectively. Note that branches of that middle cerebral artery do not actually reach any point where we reach the margin of a hemisphere, because creeping over the superior and anterior part of a hemisphere as well as the posterior and inferior part are branches of either the anterior cerebral artery or the posterior cerebral artery that supply little strips of cortical areas near the margins. But the point is, the boundary point between the different vascular supplies, as illustrated on the slide, constitutes a watershed area where there's going to be either a sensory or motor deficit that's associated with a sudden drop in arterial blood pressure, probably bilaterally, that affects parts of the motor and the sensory homunculus that are served in that watershed area. The other point we want to make is that on the lateral aspect of each hemisphere, we need to make a distinction between the lateral aspect of the left hemisphere versus the lateral aspect of the right hemisphere. And we make this point by saying that the left hemisphere is considered statistically to be the dominant hemisphere because it contains the language centers. And the language centers are Broca's area and Wernicke's area that you can see are not only in the left hemisphere, they are both localized on the lateral aspect of the left hemisphere in the vascular territory of the left middle cerebral artery. Note that the right middle cerebral artery certainly supplies the same territory, but basically the language centers are always associated with a vascular supply on the left as opposed to the right. Next, let's extend this by looking at the picture on the next slide. And all this does is show us the extent of the territory on the medial aspect of each hemisphere that's served by the anterior cerebral artery, shaded in light gray. As we've already indicated, the anterior cerebral artery is serving the lower part of the motor and the sensory homunculus, because you could see that the medial extensions of the pre- and the postcentral gyrus are located here. Again, in the darker shaded area is the vascular territory of a posterior cerebral artery. And as we've seen, its major claim to fame is to provide the blood supply to primary visual cortex that's mainly found on the medial aspect of a corresponding temporal lobe. And we'll see this a little later. Note that the corpus callosum, the massive fiber bundle that interconnects the two hemispheres, also has a dual blood supply. Most of the corpus callosum is supplied by branches of the anterior cerebral artery. But just the back piece of it, the most posterior part known as the splenium of the corpus callosum, is just supplied by branches of a posterior cerebral artery. So when we deal with patients that have what are known as disconnect syndromes, we're going to have vascular insults as part of that conversation to either the bulk of the corpus callosum or the splenium of the corpus callosum and talk about the deficits that are associated with it. Next, let's look at a summary of the different kinds of cerebrovascular causes, infarct causes, And typically they can be thrombolytic, embolytic, or the result of hypotension bilaterally or hypertension unilaterally or bilaterally. Thrombolytic infarcts usually are complications from the development of an atherosclerotic plaque, where there's a progressive narrowing of the lumen of a corresponding blood vessel, usually at branch points of that blood vessel. An embolytic infarct basically can result from a clot being thrown from a plaque, but there are lots of different sources of an embolism. Typically, when emboli are passing through cerebrovascular circulation, most commonly, if they're a carotid embolus, they are most likely to follow the middle cerebral artery and cause a blockage in, depending on the size of the embolus, one of the branches of the middle cerebral artery that's serving the lateral aspect of a corresponding hemisphere. Again, sudden drop bilaterally in arterial blood pressure might result in a so-called watershed infarct, and when this occurs, it's going to affect the area of the motor and the sensory homunculus in the area of the trunk. So these patients with a watershed cortical infarct are likely to develop what is called the person in a barrel syndrome, where they'll have bilateral sensory loss in the area of the trunk and bilateral weakness of trunk musculature, because the trunk area is right at the territory overlap between the anterior and middle cerebral artery regions. Finally, lacunar infarcts commonly result in individuals that are hypertensive, and these infarcts involve the deep penetrating or perforating branches of the proximal parts of an anterior, a middle, or a cerebral artery, and they don't cause cortical problems. They typically affect deeply placed structures either in the basal ganglia, the diencephalon, or in the internal capsule. And we'll see some manifestations of these a little later in our conversation. Next, there are several different kinds of intracranial bleeds that were reviewed in gross anatomy, but they're relevant here as well, because it's important to remember not only what the effects of such intracranial bleeds are, but what the causes are and the radiology that's associated with them. So classically, an extra or epidural hematoma is the result of a lateral skull fracture that lacerates branches of a middle cerebral artery. It can cause pooling of blood adjacent to the lateral aspect of a hemisphere. It might result in something analogous to uncal herniation and third nerve compression. But typically, these patients have a lucid interval that basically immediately precedes a sudden loss of consciousness and a deterioration of neurologic function, what we describe neurologically as the talk and die syndrome. So that's a fast-developing arterial bleed. The companion to this on the venous side is a subdural hematoma, again, usually caused by trauma to older individuals, where there is a tearing of the so-called cerebral veins, called bridging veins, at the point where they are about to enter a dural venous sinus. And these can be distinguished from a subarachnoid hemorrhage, which is the result of a bleeding baryaneurysm, which we indicated earlier occurs at the branch points of most commonly branches of the anterior circulation. And there are lots of predisposing factors to a bleeding baryaneurysm, including Marfan's, Ehlers-Danlos type 4. Patients that develop adult polycystic kidney disease are likely candidates as well for a development of a baryaneurysm. And then finally, hypertension causes that intracerebral hemorrhage and infarction that might also be seen in the form of a lacunar infarct. Let's now look at the functional localization of the lateral aspect of the left hemisphere, knowing that, as we've said previously, it is the dominant hemisphere, meaning that it contains the language centers. But before we get to those, let's provide ourselves with a complete tour of all the functionally specific areas that are located in both hemispheres equally before we talked about the language centers. As we've already discussed, we pointed out the significance of the central sulcus. You can see again represented here. And on either side of it, we have again indicated the functional localization of the primary motor cortex in the precentral gyrus and a portion of the primary somatosensory cortex in the postcentral gyrus. As we already know, it is the upper half of the motor and the sensory homunculus that is represented in an upside-down fashion in these two cortical areas. Note also that there are a number of cortical areas with functional specificity that are referred to synonymously, or can be referred to synonymously, by their Brodmann classification. The Brodmann numbers basically are a functional classification of specific cortical areas. For example, primary motor cortex is always known as Brodmann area 4. Primary somatosensory cortex is always referred to as Brodmann areas 3, 1, and 2. So exam questions can refer to a cortical area either by their functional designation, motor sensory, or by their Brodmann number in some cases. All right. Immediately adjacent to primary motor cortex is premotor cortex. This is an area of higher order motor function where these cortical neurons are mainly involved in motor planning. So as such, they're probably getting a lot of input from basal ganglia and cerebellar structures. And as we'll see in a moment, an isolated lesion of just premotor cortex won't result in any weakness. It'll result in basically in a form of an apraxia, a higher order motor deficit. Adjacent to primary somatosensory cortex is somatosensory association cortex. This is a higher order sensory cortex that is involved in the integration of what was being processed by the adjacent primary somatosensory cortex and is helping integrate that information with input from the visual system, auditory system, and other sensory systems. So we have higher cortical areas that are adjacent to the primary motor and primary somatosensory cortical areas as well. Next, look up in the frontal lobe in an area that's immediately adjacent and in front of premotor cortex. This is where we find the frontal eye fields. And since the frontal eye field that we've illustrated is on the lateral aspect of the left hemisphere, when these neurons are stimulated, they would generate a horizontal saccade contralaterally, in this case, to the right. Next, lateral aspect of each hemisphere has primary auditory cortex. Primary auditory cortex is illustrated here. It corresponds to Brodmann areas 41 and 42 and is situated on the superior bank of each temporal lobe in a corresponding hemisphere. But recognize that an isolated lesion of all of primary auditory cortex on one side would only result in a slight bilateral hearing loss and maybe a decreased ability to localize sound because of the bilateral representation of the auditory stimulus. Lastly, the other cortical area that's equally represented in both hemispheres is visual cortex. We can see just the macular cortical area that's represented here because, as we've seen, most of primary visual cortex is located on the medial aspect of a corresponding occipital lobe. All right. Now let's extend this conversation to talk about the language centers. There are three major language centers, one really being a subset of another. The three language centers that are only found on the lateral aspect statistically of the left or the dominant hemisphere are Broca's area, Wernicke's area, and kind of a subset of Wernicke's area that's known as the angular gyrus. So where these speech and language comprehension centers are located is very important. But certainly we can make the global comment that all of them are in the vascular territory of the left middle cerebral artery. All right, first, note that Broca's area, which corresponds to Brodmann numbers 44 and 45, is situated on the inferior aspect of the left frontal lobe, just in front of primary motor and premotor cortical areas that control corticobulbar neurons. So this isn't coincidence as part of the plan. It makes sense that Broca's area is adjacent to motor neurons that are controlling cranial nerves mainly bilaterally because you're activating many of the cranial nerves as part of the motor speech process. Next, look where Wernicke's area is. Wernicke's area is considered to be Brodmann area 22. It's situated mainly in the left temporal lobe, sticks out or extends a little bit into the adjacent parietal lobe. But look where Wernicke's area is. It's situated immediately adjacent to primary auditory cortex, which again makes sense because Wernicke's area is considered to function as an oral comprehension center where you understand what has been said to you. And it makes sense that it's immediately adjacent to primary auditory cortex, meaning that you hear a sound in primary auditory cortex, you understand what you hear in the immediately adjacent Wernicke's area. Now, extending out into the dominant parietal lobe in an area known as the angular gyrus is area 39. Area 39 is a written comprehension center, basically where you understand what you read. And it's situated more out in the parietal lobe because it's closer to primary visual cortex, where you see the printed words on a page. So the proximity of this makes sense because the angular gyrus is where you understand what those words mean, written comprehension. All right, so it's going to be very important now to understand where lesions are located in patients that develop language disorders. And language disorders are known as aphasias. So first, before we get there, let's summarize the cortical lesions that might involve a premotor cortex and somatosensory association cortex and the higher motor or sensory deficits associated with each. If a patient has a lesion in the so-called motor planning center, they may basically develop an apraxia. Apraxia is a disruption of the patterning and the execution, or an inability to understand how to execute the learned motor movements, but the patient will not have any weakness. So we can see an apraxia with not only a lesion of premotor cortex, but in certain parietal cortical areas as well. Secondly, a higher order somatosensory deficit may result in an agnosia. An agnosia literally means no knowledge of a specific sensation. And that's the point. When a patient develops various sensory agnosias, the lesion is particularly a cortical area that's associated with a single sensory system. So if a patient has a somatosensory agnosia, that may result in astereognosia, where a patient is unable to recognize an object just using touch modalities. So that one of the ways you might test this, if you suspect a patient that has this scenario, is that you may ask a patient to put their hand behind their back without looking and drop an object, such as a tennis ball, in the palm of their hand, and ask the patient to identify the object in their hand without using any other sensory system. A patient with a somatosensory agnosia will be able to feel the tennis ball, and they'll be able to say to you, it's a round, fuzzy, squishy thing, but they won't be able to identify it as a tennis ball because of their somatosensory agnosia. But this is the point. As soon as they introduce another sensory system into the equation, like pulling the tennis ball in front so they can see it, they'll immediately be able to overcome their deficit and identify the object as a tennis ball, but that only occurred when they introduced a different sensory system into the equation. And for unknown reasons, it turns out that both an apraxia and a higher order somatosensory deficit seem to be more common in left hemisphere damage than right. Now, let's begin to classify the different forms of the aphasias. These are disorders of language that result when there's a lesion of Broca's area, Wernicke's area, the written comprehension center, and or a fiber bundle that connects those areas. So we need to come up with, obviously, different clinical scenarios for a number of aphasias. First point we want to make before we get into the details is all aphasias have two features to them. One is they disrupt your ability to write. They present with forms of dysgraphia because writing is a highly acquired specific secondary communication skill that probably means that all of the language centers have to be intact. Second, patients with aphasias will have a decreased ability to repeat after an examiner or answer an examiner's verbal questions. So let's see how that plays in when we talk about the specific aphasias. When a patient has a lesion to Broca's area, what they develop is known as logically a Broca's aphasia, but note that the exams are trying to get away from the eponyms, and they'll frequently describe this condition as being an expressive, a motor, or a non-fluent aphasia. So in this patient, obviously the motor speech center has been disrupted by a left middle cerebral artery infarct. So the patient's verbal output is reduced to the use of single syllable words. And this patient is going to be very frustrated by their deficit, because they'll understand all of the verbal commands that are being asked of them by an examiner, so they'll hear them and understand them, but they will have a decreased ability to respond to an examiner's question by using anything more than single-syllable words. So this patient is going to be very aware and frustrated by their expressive aphasia, where their speech output is reduced to the use of single-syllable words. And obviously the corollary of this is, if the damage extends into the adjacent primary motor cortex, the patient might, at a minimum, have a contralateral lower face weakness, in this case on the right, drooping of the corner of the mouth on the right, and if the lesion involves adjacent areas of the left primary motor cortex, they might also develop a right upper limb spastic weakness. Now, let's contrast this aphasia with a patient that has a receptive or a sensory or a fluent aphasia. And this is emblematic of a patient that has a lesion in the dominant temporal lobe, mainly in the area 22, which is our oral comprehension center. So if the lesion is restricted to area 22, this patient will have an oral or a sensory aphasia where they will not be able to understand what has been said to them. And their verbal output will be relatively normal, but for lack of, we don't actually know why this occurs, these patients tend to misuse words, often speaking in what we call a word salad, as if they went through a buffet and just put a random array of words in a sentence and tried to use them in that fashion. So these patients have paraphasic speech. They misuse common words in basically what is normally a fluent verbalization. But in contrast to the expressive aphasia patient, these patients are generally aware and not concerned by their deficit. They are typically older individuals and think they are just suffering from a hearing loss, which they may also have, and think they probably ought to get a hearing aid, but it's more than that. They may have the hearing loss because of the adjacent involvement of primary auditory cortex, but it's more than that. These patients do not understand what has been said to them. Next, if the lesion is not to Wernicke's area, which is pure area 22, but is confined to the dominant inferior parietal lobe in the area of the angular gyrus, the patient may present with the signs and symptoms of Gerstmann's syndrome. These patients, since you are involving the written comprehension center, will develop a form of alexia. But in addition, since it involves a language comprehension center, they're also unlikely to be able to write as well. So the two initial presenting signs and symptoms seen in this patient are alexia and agraphia, emblematic of a dominant parietal lobe angular gyrus lesion. In addition, these patients, because of the proximity to the somatosensory association cortex, also present with two additional interesting signs, not related to, obviously, the aphasia that they have. They present with dys or acalculia. They have difficulty adding their checkbook up at the end of the week or the end of the day, difficulty performing simple math problems. And they also have an interesting agnosia. It's a form of a somatosensory agnosia known as finger agnosia. These patients can still feel their fingers, but particularly on their right hand, they will not be able to point to or recognize which fingers are which because of the proximity of the angular gyrus to the left somatosensory association cortex. So this patient will have Gerstmann's syndrome. It's only found in the dominant parietal lobe, and they are likely to have alexia and agraphia, dys or acalculia, and finger agnosia. And it's thought that the acalculia and the finger agnosia are seen with the same cortical lesion because of the fact that when you began counting as a child, you used your fingers to go from 1, 2, 3, 4, 5. Next, what if the aphasia is caused by not a direct lesion to Broca's area, Wernicke's area, or the angular gyrus, but is in the form of a disconnect syndrome where the lesion is not to a functionally localized cortical area, but it's to a fiber bundle that interconnects the language centers. And the fiber bundle that interconnects Broca's, the angular gyrus, and Wernicke's area is known as the arcuate fasciculus. It's known as the arcuate fasciculus. This arch-like fiber bundle basically is an association fiber bundle that runs between the temporal lobe, the parietal lobe, and the frontal lobe, connecting all the language centers. And functionally, we say that the function of this bundle is allow an individual to put thoughts into words or to respond to a verbally directed question that they fully understand. So here's the difference. Since the lesion is not to Broca's area, their speech output basically is going to be relatively fluent and normal, although they may misuse words. Since the lesion is not to Wernicke's area or the angular gyrus, their language comprehension skills will also be normal. So what is the characteristic feature of this aphasia? This patient basically cannot repeat words or execute verbal commands when asked to do so by an examiner because they have lost the connection between the language comprehension centers and the motor speech center in Broca's area. So meaning that this patient will be able to hear and understand a verbal command, such as count backwards from 100, beginning at 100, but they won't be able to execute the command verbally because there has been a disconnect between the language comprehension centers and the motor speech center. So this is a patient that has a disconnect syndrome that constitutes a conduction aphasia, but it's also known as a repetitive aphasia because all of the language centers are intact, but the patient is unable to verbally answer or respond to an examiner's questions. And at the bottom of the slide, we make the point that, like an expressive aphasia, the patient is going to be keenly aware and frustrated by their conduction aphasia. So we kind of say it this way. A patient with an expressive aphasia and a conduction aphasia is going to be keenly aware and frustrated by their deficit, whereas a patient with a Wernicke's aphasia and or Gerstmann syndrome is generally going to be unaware and or not necessarily frustrated by their comprehension aphasia. All right, now let's extend this to talk about a lesion that might occur in the non-dominant parietal lobe in the exact area or similar area that was represented by the angular gyrus in the dominant lobe. So in the angular gyrus region of the left parietal lobe, we had a patient that developed Gerstmann syndrome. In the corresponding area in the non-dominant right parietal lobe, if lesioned, this patient doesn't develop Gerstmann syndrome, they develop what's called unilateral neglect. And since the lesion is in the right parietal lobe, although their sensation tends to be intact, the patient has a higher order dysfunction that results in them ignoring the left side of their visual and somatosensory world. So this patient with the right or non-dominant parietal lobe lesion no longer takes care of themselves, dresses themselves on the left side. If they're a woman, they will no longer put makeup on or take care of their hair on the left side. A male patient with this won't shave the left side of their face, and they will fail to recognize basically anything in their left visual and or somatosensory world. Fortunately, this is usually transient, but the classic test for this patient is to ask them to either bisect a line or draw the numbers on a clock face. A patient with a unilateral neglect syndrome will try to cram all 12 numbers on the right half of the clock face because they don't think that the left half of the clock face exists. Finally, patients might develop what's known as a visual agnosia. We've talked about a patient that has a somatosensory agnosia. This is a patient that has a lesion of what we call the visual projections going into the temporal lobes. And the temporal lobes are an area of basically higher visual processing that's associated with object recognition and color recognition, mainly manifesting through what's called the cone stream. So when you have an association lesion in temporal cortex, patients might develop a visual agnosia, commonly in the form of a prosopagnosia, where they have a decreased ability to recognize the faces of friends or familiar family members. So since the lesion is localized just to the cone stream going into the temporal lobe, they typically are able to read because the lesion is not directly affecting a language center, and they can name objects because visual cortex itself is intact, and they can see and recognize the object and verbalize what it is. So prosopagnosia seems to be a visual agnosia that is unique to temporal lobe infarcts. But again, like typical of an agnosia, as soon as another sensory system is introduced in the equation, such as the patient or the friend or the family member that they don't recognize says something, the patient will immediately be able to recognize who the face belongs to because another sensory system was introduced into the equation. Next, let's extend our conversation to talk about a couple of other disconnect syndromes. The first one that we illustrated earlier was a disconnect syndrome that only involved the left hemisphere, where we disconnected language centers caused by the lesion to the arcuate fasciculus that connected them. These two other disconnect syndromes involve specific lesions to parts of the corpus callosum, again, vascular insults. And the first one results in what's called transcortical apraxia that results from a vascular occlusion of just the corpus callosal branches of the anterior cerebral artery. Because as we said earlier, about 4/5 of the corpus callosum is in the vascular territory of the ACA. So here's the scenario. This patient has a transcortical apraxia where they're going to have an inability to move the left arm in response to a verbal command. Because here's how it works. Let's say an examiner asks an apraxia patient such as this one to execute a simple command using their left upper limb, such as reach forward and grab a cup of coffee and take a drink. As you recall, the patient will hear this command bilaterally, but they will only be able to understand the command in the Wernicke's area that's in the left hemisphere. And because of the vascular insult and the lesion of the corpus callosum, the command to move the left arm in response to a verbal command cannot be interpreted because the command information cannot get across the lesion corpus callosum to the right motor cortex, because as we know, the right motor cortex is controlling movements of the left upper limb. So this disconnect syndrome disconnects the right motor cortex from the language comprehension centers as a result of the corpus callosum lesion. But by contrast, the patient could execute the same command only by using their right upper limb instead of their left, because you can see on this picture, you again will hear the command and understand the command in Wernicke's area, but the left motor cortex is in the same hemisphere and not affected by this disconnect syndrome involving the corpus callosum. The next slide again summarizes the results of an infarct of that ACA. So again, the patient's not going to have any motor weakness because the lesion does not involve upper motor neurons, specifically at cortical areas. It is a disconnect lesion that affects most of the corpus callosum itself that, as we said, is disconnecting the Wernicke center, where I understand a verbal command, basically from the right motor cortex. Let's now extend this to talk about the other callosal disconnect syndrome. And this is one where I have just an isolated occlusion of the left posterior cerebral artery. So as we've seen earlier, a complete vascular insult of the left posterior cerebral artery is likely to present itself with a right homonymous hemianopsia with macular sparing. But if the vascular insult to the left posterior cerebral artery also involves the splenium of the corpus callosum, this patient will have additional signs and symptoms that constitute this infarct. So they will present with alexia without agraphia. Because here's the scenario. This patient will still be able to see everything in their right visual cortex, and they will be able to read words or see words on a printed page in their intact right visual cortex. But because of the lesion to the splenium of the corpus callosum, the visual information about what they see printed on a page cannot cross the splenium of the corpus callosum and reach the area of the angular gyrus in the left or dominant hemisphere. So basically this patient has alexia, but they'll still be able to write theoretically because all of the language centers themselves are intact. Even though they may be able to write, they won't be able to read what they wrote. So remember the distinction. Patients that develop alexia without agraphia have a left posterior cerebral artery infarct where they certainly are going to have the homonymous hemianopsia, but the infarct involves the splenium of the corpus callosum. And contrast that with a patient that had Gerstmann syndrome in the dominant parietal lobe. That patient had alexia with agraphia because of the language center involvement, along with the dyscalculia and the finger agnosia. All right. So again, we're summarizing it on the next page with regard to the patient that has a splenium of the corpus callosum lesion, and we're just documenting in a text form. It's another higher order deficit that's associated not just with the occipital lobe damage and the hemianopsia. They have a splenium of the corpus callosum lesion that basically, even though they can see words on a printed page in the intact right hemisphere, they're unable to read because of the infarct involving the splenium of the corpus callosum. Next, let's now extend our cortical conversation to include a large fiber bundle that carries all of the axons into and out of each hemisphere. And this is certainly the function of the axons that course in the internal capsule. The best way to visualize the anatomy of the entire internal capsule is to see it in a horizontal section. And in a horizontal section, we can see that each internal capsule is V-shaped and basically is in the form of an anterior limb and a posterior limb, and the two limbs come together at the apex of the V that's known as the genu. Look not only where the internal capsule is, but what neural structures lie on corresponding sides of it. Note that the anterior limb of the internal capsule is separated exclusively by basal ganglia structures. On the medial side of it, bulging into the lateral ventricle, is the head of the caudate nucleus. On the lateral side of the anterior limb of the internal capsule are parts of the putamen and both segments of the globus pallidus. On the medial side of the posterior limb of the internal capsule is the thalamus, and you can see its array, and it's closely associated with the third ventricle. Now, it's very important to visualize or recognize what the blood supply to different parts of the internal capsule is and the effects of infarcts of those blood vessels. So the blood supply to the internal capsule parts are illustrated. It's illustrated on the next slide. Note that the blood supply to the internal capsule is served by deep or perforating branches of the anterior and middle cerebral arteries. And when these deep perforating or penetrating branches are involved, they are the cause, usually in hypertensive patients, of various lacunar strokes. Note the difference. Note that the anterior limb of the internal capsule is supplied by medial striate branches of the anterior cerebral artery. But the point is that much of what is going through the anterior limb of the internal capsule is going up to the more rostral parts of the frontal lobes. So it's very difficult to localize a lesion just to the anterior limb of the internal capsule because of lack of specificity other than limbic, which can be the result of lesions in lots of places, of the axons traversing it. But that changes when we get to the genu and the posterior limb. Running through the genu are all of the corticobulbar fibers that are serving cranial nerves, all of them. And the corticobulbar region of the internal capsule in the genu is in the vascular territory of lenticulostriate branches of a corresponding middle cerebral artery. So since, as we know, that cranial nerve lower motor neurons are predominantly bilaterally innervated, a genu infarct will probably not result in signs and symptoms other than a contralateral lower face weakness, because we know that just the lower motor neurons to muscles around the nose and the mouth are only getting a contralateral corticobulbar innervation. The most clinically relevant part of the internal capsule is the posterior limb, again in the vascular territory of lenticulostriate branches of the middle cerebral artery. Here, some old friends are going up or down through the internal capsule. All of the corticospinal axons to the entire motor homunculus are descending through the posterior limb, meaning that a corticospinal lesion in the posterior limb will result in a contralateral spastic weakness of both the upper and the lower limb. meaning that you can distinguish a posterior limb infarct from a cortical vascular insult involving either the anterior or the middle cerebral artery separately, which will only affect part of the motor homunculus. Secondly, all of the thalamocortical somatosensory projections are ascending from VPL and VPM of the thalamus up through the posterior limb of the internal capsule to primary somatosensory cortex. So again, if these fibers were affected by a lacunar stroke, the patient would have a complete contralateral anesthesia for all sensory modalities, including upper limb, lower limb, trunk, as well as face, because the entire thalamic outflow to somatosensory cortex will be affected. So JNU and particularly posterior limb infarcts involving the internal capsule are particularly devastating neurologically. Next, let's kind of summarize the signs and symptoms and using a couple of charts and make some distinguishing features about them if a patient develops vascular insults of the vertebrobasilar system versus the carotid system. So note that the vertebral arteries themselves supply parts of the anterior two-thirds of the spinal cord by feeder arteries, not just coming from the vertebrals, but also from intercostals as well. In the area of the medulla, we know that the anterior spinal artery is also supplied in the medial aspect of the medulla. So if we were to have a vascular insult involving the feeder arteries that serve the anterior spinal at the area of the spinal cord, the neurologic signs and symptoms would involve two of our three fundamental neural systems. The patient would have a bilateral loss of pain and temperature below the lesion, bilateral spastic weakness below the lesion, but sensations carried by the dorsal columns will be spared because the dorsal columns are in the vascular territory of a pair of posterior spinal arteries, not the anterior spinal. And again, the distinction you want to be able to make is a patient that has ALS will also have the same kind of motor pattern of loss. But a patient with ALS, which is a degenerative disease, their signs and symptoms will be limited to motor problems, whereas a patient with a spinal artery infarct will also have the same motor problems, but will also have a bilateral loss of pain and temperature, a sensory deficit. Next, pica is probably the most famous single pair of arteries that branch from the vertebrals, and pica lesions result in lateral medullary or Wallenberg syndrome, where the common effects involve lateral tracts running in that area of the medulla, including spinothalamic and the descending hypothalamic fibers, and an involvement probably of cranial nerves 9 and 10. Moving on to the basilar artery. Basilar artery is, through its paramedian branches, serves the medial aspect of the pons, and lesions that are or disruptions of that vascular territory commonly result in medial pontine syndrome. And going back to brainstem anatomy, remember, when you have a brainstem vascular insult, you're typically going to involve at least one of the long tracts, and what will localize the lesion for you will be the affected cranial nerve. So medial pontine syndrome typically presents with a corticospinal tract lesion and a contralateral spastic weakness, and ipsilateral involvement usually of cranial nerve 6 if it's in the caudal and medial pons, resulting in an internal strabismus. AICA, the other named branch, the major named branch of the basilar system, supplies the area of the cerebellum, as its name implies, but it also may be involved in lateral pontine syndrome, where again we affect the same long tracts that we saw in lateral medullary syndrome, spinothalamic and descending hypothalamic fibers. But what localizes the lesion to the lateral pons is the corresponding involvement of cranial nerve 7, ipsilateral facial weakness, and or cranial nerve 8, and ipsilateral sensory neural hearing loss. Then, the other two branches of the basilar system are superior cerebellar. Typically, this is a rostral pons blood vessel, rostral and lateral pons, that affects the same tracts as a caudal and lateral pons lesion, but the cranial nerve that's involved is much more likely to be 5 as opposed to 7 and 8. Labyrinthine artery commonly comes either directly off the basilar, it may come off AICA, and its job is to supply the inner ear, and if there's an isolated infarct of this blood vessel associated with this blood vessel, the patient will present with a pronounced ipsilateral sensory neural hearing loss. Then, finally, we know that the basilar arteries bifurcate to form a pair of posterior cerebral arteries, and they have obviously a number of jobs. They are the sole source of arterial blood supply to the midbrain. So patients might have a medial or a lateral midbrain syndrome affecting tracts and commonly cranial nerve 3. The thalamus is served by perforating branches of those cerebral arteries, but certainly the major destination, as we've said cortically, of the posterior cerebral artery is to supply the occipital lobe in the area of primary visual cortex. And as we know, vascular insult of PCA will result in a contralateral homonymous hemianopsia with macular sparing, and if the left posterior cerebral artery is involved, and if that left PCA's vascular territory to the splenium is also included, the patient may have that same right homonymous hemianopsia with macular sparing, but they may also develop alexia without agraphia if the splenium, only on the left side, is disconnected. It's disconnecting visual cortex from the angular gyrus. Then, internal carotid anterior circulation. Before the internal carotid branches into the anterior and middle cerebral arteries, it gives off the ophthalmic artery that supplies the orbit, but its claim to fame clinically is it gives rise to the sole source of the arterial blood supply to the retina, central artery of the retina, which is an anatomic end artery, which if occluded would cause a monocular anopsia of the corresponding eye. Posterior communicating artery, as we know, there are two of them. They connect the anterior and the posterior circulations. At branch points of that posterior communicating artery is another common site, the second most common site of the development of a barrianeurysm. Then, anterior cerebral artery, we've documented somewhat extensively. We know that in terms of primary motor and primary somatosensory cortex, it is serving the lower part of the motor and the sensory homunculus contralaterally. So the patient would have either bladder problems, weakness, and or anesthesia of the contralateral lower limb. In addition, patients might have higher order frontal lobe dysfunction because much of the frontal lobe is in the vascular territory of ACA. Next, anterior communicating arteries claim to fame. Yes, it connects the anterior circulation together by joining the anterior cerebrals, but as we said, its major claim to fame is that it's the most common site of development of a barrianeurysm, and typically in its initial presentation, it kind of acts like a craniopharyngioma in that it typically or commonly compresses the top of the crossing fibers in the optic chiasm, resulting at least initially in a bitemporal inferior homonymous quadrantenopsia. Then, moving to the cortical branches of the internal carotid, the others, certainly a major one is the middle cerebral artery, and we know in terms of the outer aspect of cortex, it's supplying the upper half of the motor and the sensory homunculus, and if obviously occluded would cause a contralateral spastic weakness of the lower face and upper limb, contralateral anesthesia of the same areas. It may cause a gaze dysfunction, where basically you will be unable to gaze away from the lesion hemisphere because of the involvement of the corresponding frontal eye field. And now, we haven't pointed this out before, we'll make the point now. We know certainly that the left middle cerebral artery is important because it supplies all of the language centers. So statistically, if there are left middle cerebral artery infarcts, patients are likely to develop, depending on the location of the infarct, Broca's aphasia, Wernicke's aphasia, Gerstmann syndrome, or a conduction aphasia. But the point we want to make on this slide is, what if there was an involvement of branches of the right middle cerebral artery that are serving areas where the language centers would be if they were located in the right hemisphere? So the point we want to make is, if there is a disruption or a lesion of the area that would correspond to Broca's area or Wernicke's area in the non-dominant hemisphere, the patient won't develop aphasias. They'll develop dysprosodias, where they will either be unable to convey a normal emotional content to speech, or they won't be able to understand the emotional content of speech because of the lesion on the non-dominant or the right hemisphere. And again, extending this, if the lesion were back in the left dominant or parietal lobe, the patient would have Gerstmann syndrome, but the corresponding area in the right parietal lobe would cause unilateral or hemi-neglect. Then, let's extend this, and in essence, sort of saying the same thing, because in a way, exam questions can be generated with signs and symptoms neurologically, and exam questions can ask you what lobe or region of a lobe might be the location of a lesion rather than what vascular supply might be disrupted. So there's a lot of overlap in here, but we're just making the point about lobal localization as opposed to vascular localization. So we know in the frontal lobe is mainly a motor area of cortex, except for our personality traits, which are lodged in prefrontal cortex. As we said, when we have motor problems involving frontal lobe, we're affecting either the primary motor or premotor cortex, and the patient will develop, obviously, the contralateral spastic weakness in the corresponding vascular territory of the homunculus and or the apraxia associated with premotor cortex. And again, if you have a frontal eye field lesion, the patient cannot look away from the lesion hemisphere, and the eyes will tend to deviate toward the side of the lesion hemisphere. But we know certainly in the left frontal lobe, we have Broca's area, and Broca's area lesions result in an expressive or non-fluent aphasia. But being a little more precise now, if we lesion the area where Broca's area would be in the non-dominant frontal lobe, the patient will have a motor dysprosodia, where their speech output will be normal and fluid, but they will be unable to convey an emotional content to that speech. So they may speak basically in a monotone, so you won't know based on the patient's normal speech whether they're excited, happy, sad, or angry, because they cannot convey or add an emotional content to speech. Then, parietal lobe, same story. We know that the parietal lobe contains primary somatosensory cortex, and if there's a vascular insult to that, the patient, depending on the blood vessel involved, will have different forms of a contralateral hemianesthesia, either involving the upper half of the homunculus or the lower half of the homunculus. If the lesion extends out into somatosensory association cortex, they could develop an astereognosis contralaterally and or also develop a form of an apraxia. And we've documented this as well. In the left hemisphere, left parietal lobe, if lesion will result in Gerstmann syndrome, whereas if it's in the right or non-dominant parietal lobe, as we've said, the patient is likely to develop the unilateral neglect. Then temporal lobe. We know that temporal lobe is home bilaterally of primary auditory cortex, and since of the bilateral representation above the superior olive, if there were a unilateral lesion of primary auditory cortex in one temporal lobe, the patient would not have a significant hearing loss. It would only be a slight bilateral one. We know that Wernicke's area is mainly found, area 22, in the dominant or left temporal lobe and is the location of our oral comprehension center. But again, making the analogy, if I have a Wernicke's area lesion in the left hemisphere, I'm going to have a receptive or fluent aphasia. If I have a lesion where Wernicke's area might have been in the non-dominant or the right temporal lobe, the patient will have a sensory dysprosodia, where again, their speech output will be normal, their oral comprehension will be normal, but they will not be able to understand the emotional content of someone else's speech because of the lesion to the right temporal lobe. And as we'll see when we get to the limbic system, the hippocampal formation and the amygdala are major temporal lobe structures that are represented bilaterally. The hippocampus is a major memory consolidation site where it takes all of your learned information and begins to consolidate it into a short and then a long-term stored memory. Immediately adjacent to the hippocampus will be the amygdala, and the amygdala is our emotional response center. It helps us attach an emotional significance or an emotional component to a memory. And classically, bilateral amygdala lesions result in an individual that becomes placid to all external stimuli in a patient that has Kluver-Bucy syndrome. The other important point about the medial aspect of the temporal lobe, it's a major site of projection of olfactory information. And an isolated temporal lobe lesion might result in an ipsilateral anosmia, a loss of the sense of smell, but there are going to be some other lesions that are more commonly associated with that, with an anosmia. And the other very important point about the temporal lobe is that, as we indicated in visual processing, it's a part of the brain where the visual radiations, just representing the upper contralateral quadrants, make a little hairpin loop through the temporal lobe on their way from the lateral geniculate body before turning posteriorly to head back to primary visual cortex. So we can have an isolated temporal lobe infarct, because the rostral tip of it is supplied by middle cerebral artery, or a temporal lobe tumor that causes a lesion of Meyer's loop and a contralateral homonymous superior quadrant defect, or a pie in the sky deficit, as we've described. And then finally, the occipital cortex is the location of primary visual, and we know that the entire blood supply to the occipital lobe is served by branches of the posterior cerebral artery. If it's bilateral, the patient will have cortical blindness, but an intact pupillary light reflex. If unilateral, as we know, PCA infarcts result in a contralateral homonymous hemianopsia that's usually seen with macular sparing.